Okay, so today we'll continue our discussion regarding regarding lipids, and we'll talk about lipoproteins today. So for lipoproteins, it's a combination of lipids and proteins, and the protein component of lipoprotein, it's called apolipoprotein. Okay, and the function of lipoprotein is to transport substances like cholesterol and triglyceride. Okay, so the transport mechanism or the carrier protein of cholesterol and triglyceride, they have lipoproteins. So the function of the protein component of the lipoprotein is to react with the receptor, okay, which is present on the surface of the cell. Okay, so and when we talk about amphipathic helix, this is the ability of protein um, to bind with lipids. Okay, and another function of apolipoprotein, it maintains the structural integrity of the lipoprotein complex. Okay, so that is for your lipoproteins, the component of your lipoproteins. You have lipid and proteins, and the protein component of lipoprotein, it's called apolipoprotein. So next is, what are the major lipoproteins? So for major lipoproteins, first we have chylomicrons. Okay, so for chylomicrons, it's the largest lipoprotein, and it is the least dense. So later we'll discuss or we'll explain why it's the largest and the least dense of all the major lipoproteins. Okay, and it is cleared within 6 to 9 hours postprandial. Okay, so it is absent in uh, fasting serum or fasting specimen because it's cleared 6 to 9 hours postprandial. And for lipoprotein measurements, specifically for LDL, uh, VLDL, you need to fast for at least 12 hours. And for chylomicrons is cleared or it's absent or it's usually removed from your system 6 to 9 hours postprandial, or 6 to 9 hours after eating. Okay, and for chylomicrons, it is produced by the intestine and it transport exogenous triglyceride. Okay, so the function of chylomicrons is to transport exogenous tag, the tag being absorbed, or to transfer the triglyceride or tag and chole, primarily tag. Okay, transport the tag and chole absorbed by the intestine. So if this is the intestine, the function of chylomicrons is to transport the absorbed tag and chole from the intestine or from your system to your liver. Okay, so that is the function of um, chylomicrons. Okay, to transport the absorbed lipids to the liver, primarily triglyceride. Okay, so in terms of absorption, the body absorbs 50% of the cholesterol intake and 80 to 95% of the triglyceride intake. Okay, and the function of chylomicrons is to transport those absorbed lipids to the liver. Okay, so it's responsible for exogenous pathway. Okay, or the transport of exogenous lipids to the liver. Now, regarding the apolipoproteins, which is predominant in the chylomicrons, it's ApoB48. Okay, predominant, followed by ApoA1, ApoC, and ApoE. Okay, so these are the apolipoproteins which are present in chylomicrons. The abundant or the predominant one is ApoB48. Okay, then next, we have VLDL. Okay, so for VLDL, it's secreted by the liver and it transport exogenous tag. Okay, so the function of VLDL is to transport the triglyceride formed by your liver to the different parts of or to different peripheral tissues that require triglyceride. Okay, And that triglyceride is the endogenous type of triglyceride because it's formed or produced by the liver. Now, regarding VLDL, VLDL is atherogenic. Okay, so it can cause atherosclerosis. So, regarding atherosclerosis, I'll just discuss later what is the um, pathophysiology of atherosclerosis. Okay, then the most abundant apolipoprotein in VLDL, it is ApoB100, followed by ApoC and ApoE. Okay, so ApoB100, that's for VLDL. For chylomicrons, it's ApoB48. Okay. Next is you have the lipoprotein HDL. So HDL, or high density lipoprotein. High density lipoprotein, also known as your alpha lipoprotein. For VLDL, that is your pre-beta lipoprotein. Okay, so HDL is the smallest. Okay, so we'll discuss later why it's the smallest lipoprotein and the most dense. And it's produced by the liver and intestine, and it's responsible for the reverse cholesterol transport. Okay, and for the reference method, um, ultracentrifugation. Okay, if you want to determine HDL concentration, the best or the reference method for HDL measurement is ultracentrifugation. But you can also perform chemical precipitation reaction for HDL, but that is the routine method for HDL measurement. Now, the predominant apolipoprotein in HDL, it is ApoA1, followed by ApoA2 and ApoC. Okay, and it has high phospholipid content. Okay, and if the concentration of your HDL is less than 35, then you're of high risk for atherosclerosis or cardiovascular disease. And greater than 60, it's heart protective. High means protective or heart protective, so we are not prone to cardiovascular disease. Okay, so women tend to have higher HDL concentration because estrogen, okay, increases HDL concentration. Okay, so that's the relationship of HDL to estrogen, and that's why women have less risk or lower risk of CVD before menopause or after menopause. It's uh, because of increased estrogen concentration that increases HDL. Okay. Then next, you have LDL. So LDL, or low density lipoprotein, or beta lipoprotein. And for the production, it's the product of VLDL catabolism, which originates from your liver. Okay, so it is the end product of VLDL catabolism, and it's the most abundant lipoprotein. So remember, the most abundant lipoprotein, it is LDL. Why LDL? It's because LDL is important in the transportation, okay, of cholesterol from your liver to the different parts of, or to different peripheral tissues, because cholesterol is important in different processes of our body, and for example, estrogen production, bile acid formation, vitamin D formation, and fluidity of the cell membrane. Okay, and it transport cholesterol to peripheral tissues, and it has the highest cholesterol concentration, so most cholesterol rich lipoprotein, and it is the most atherogenic. Okay, and it is the better marker of CHD, or coronary heart disease risk, and it's also the primary target of cholesterol lowering therapy. Okay, the predominant apolipoprotein, it's ApoB100. Okay, and another, we have ApoE, okay? And the reference range for LDL, it is less than 100 mg per TL. Okay, so that is for LDL. So those are the four major lipoproteins. Okay, so regarding the concentration, okay, or composition of each major lipoprotein. So for chylomicrons, it has the highest triglyceride concentration because it carries exogenous triglyceride. Okay, and the lowest protein concentration. That's why it's the largest and the least dense. Least dense because of low protein concentration, largest because of increased triglyceride concentration. Then for HDL, HDL is the smallest because of low triglyceride concentration, and most dense because of increased protein concentration. So protein is terms of heavy ba siya or dili, mas heavy ang protein compared to triglyceride. Okay? So for VLDL, the most abundant component, it is TAG because it's the carrier of endogenous triglyceride. For LDL, the most abundant, it is cholesterol ester, 45 to 50%. Okay? So that is for your lipoproteins. Okay? And regarding the endogenous exogenous pathway of your lipoprotein, so first let's talk about the flow in the absorption, the endogenous pathway and exogenous pathway, and the reverse cholesterol transport of the lipids and lipoproteins. So first, di ba, you have your intestine. So for example, this is the intestine. The function of intestine is to absorb nutrients. So example, absorption of lipids. Okay, so lipids. Now, to use this one, your body needs to transport transport the absorbed lipids to your liver. So this is the liver, this is the intestine. Okay, so the function or the first step is to absorb. Second is to transport the absorbed lipid, primarily triglyceride, to the liver. Okay, and the lipoprotein responsible of doing that is your chylomicrons. Okay, so chylomicrons is responsible for the exogenous pathway. So it transport the absorbed lipid, okay, to your liver. Okay, the next is to the distribution of triglyceride to different parts of your body. So next is your liver produce VLDL, and this VLDL contains high concentration of triglyceride because it carries or transport endogenous triglyceride or the triglyceride produced by your liver. Okay, so after that, we'll start with the endogenous pathway. Okay, after the transport of lipids from intestine to liver, that's for exogenous. The next step is endogenous pathway. So for endogenous pathway, first you have your VLDL that carries or transport uh, primarily endogenous triglyceride. Okay, the next is you have the once the VLDL perform its function na, the next is to convert this one to LDL. Okay, and the enzyme needed for the conversion of this one to LDL, you have your LPL or your lipoprotein lipase. Okay, so in that conversion or catabolism of VLDL, the product is your LDL. Now, for LDL, the function of your LDL is to carry, okay, cholesterol. The main component of LDL is cholesterol na. Okay? So for that LDL, the function of that LDL is to uh, distribute the cholesterol present, okay, or being carried by the LDL to the different cells. Okay, so for example, this is the cell. It has an LDL receptor. So this LDL receptor will bind with the LDL, and after that binding, endocytosis will happen. And next is the liberation of cholesterol or distribution of cholesterol to the cell. Okay. So that's how LDL distribute its cholesterol. Now, what if this cell contains high levels of cholesterol na? So, in excess na of cholesterol. So, to remove the excess cholesterol, you need the lipoprotein HDL. Okay? So, this HDL will remove the excess chole from this cell, okay, using the enzyme L. okay, or lecithin cholesterol acyl transferase. Okay, so you remove the excess chole, and the HDL will bring this excess chole to the liver, okay, for excretion. Okay, now for the excretion, it's either your liver will excrete directly the cholesterol to your intestine, okay, or through bile, or combine that cholesterol or process that cholesterol to form bile acid. Okay, so the first way is to excrete cholesterol via bile directly. Okay, second is to process that cholesterol to form bile acid, and after that you use bile acid, or bile acid is one of the components of your bile. The next is the excretion of bile acid. Now that bile acid and your bile is also important for the absorption of the new set, or the new set of lipids being ingested. Okay, so it's a continuous flow of ingestion. Then after that, you have excretion of your lipids. Now, another way, if there's an excess amount of LDL that contains cholesterol, these LDL can also transfer uh, excess cholesterol to HDL using CETP, or cholesterol ester transfer protein. Okay, so that's how the uh, our body um, process and transport lipids. Okay, so this one right here, this is the exogenous pathway. This one, from this area to this one, you have the endogenous pathway. And for this one is the reverse cholesterol transport up to this one. Okay, reverse cholesterol transport. So for reverse cholesterol transport, the HDL remove excess cholesterol from the cell and transport that one back to the liver. Okay, so that's the explanation of your or the pathway for your lipoproteins and lipids. Now, regarding the pathophysiology of atherosclerosis, when you say atherosclerosis, diba, it's the buildup of plaque or the occlusion of the artery. Okay. Now, the lipoproteins, major lipoproteins that are atherogenic, you have your VLDL and LDL. Okay. So let's talk about the flow, okay, or the pathogenesis. Okay, so for example, diba, you have your liver that produce VLDL, then convert this one to LDL. Okay, so for example, there's a problem with the receptor of the cell, or the LDL receptor of the cell. So the LDL cannot offload, okay, or cannot distribute the cholesterol that it carries to the cell because there's a problem with the receptor. So the LDL lipoproteins will, or LDL will accumulate in the system or in your circulatory system. So after that, if there's accumulation of LDL, some of the LDL will be oxidized. Okay, so there is oxidation of LDL. And if there is oxidation elicits an immune response. Okay, so it activates your immune response, and your immune response will send macrophages to that area. Okay, now that macrophage, if this is the macrophage, the function of macrophage, diba, is to engulf antigen. So in this situation, the macrophage will engulf the oxidized form of LDL. Now, the problem with this engulfment, uh, the macrophage cannot digest the LDL molecule. Okay, since the macrophage cannot digest the LDL molecule, this macrophage will become foam cell. Okay, foamy cell or foam cell. And this foam cell will tend to accumulate in the lining, okay, of your artery. Okay, so you have your foam cell. So the next time you have increased LDL concentration, uh, same process, you have oxidation of LDL, engulfment of LDL by the macrophage, and after that you have the formation of foam cell. So that new foam cell will deposit again, and deposit and deposit and deposit of foam cell, and that causes occlusion of the artery. Okay, and since there's occlusion, that can cause low or decrease or absence of oxygen delivery to tissues. And if there's decrease or absence of oxygen delivery to the tissues, that can cause death to that particular tissue. And that is your acute myocardial infarction. Okay? So, this one can cause AMI or myocardial infarction sa heart, and sa brain, it can cause stroke. Okay? So that's the pathogenesis of atherosclerosis. So atherosclerosis, you have buildup of fat, okay, in the artery, and that fat is your foam cell. Foam cell is a macrophage with an engulfed LDL, oxidized form of LDL. Okay, so that's the pathogenesis of what they call this. Um, Atherosclerosis. Okay. Next, you have minor lipoproteins. So for minor lipoproteins, first you have intermediate density lipoprotein or IDL. So it's a product of VL catabolism, or also known as your VLDL remnant. So for the catabolism of your VLDL, so you have your VLDL, then it will be converted to IDL, and the end product you have your LDL. Okay. So first, you have your VLDL, IDL, and last, you have your LDL. So for this one, in electrophoresis, it's either migrate either in the pre-beta or beta region. So in between, that's the migration, or that's the location of your intermediate density lipoprotein. Then the major lipoprotein or apolipoprotein in intermediate density lipoprotein, it's ApoB100. Okay, so if there's ApoB100, usually that's atherogenic. Like, same with VLDL and LDL. The next is lipoprotein A. So for lipoprotein A, similar to LDL in terms of density and composition, but the migration is pre-beta region. Okay, now let's talk about ultracentrifugation and uh, electrophoresis. So in ultracentrifuge, okay, so if this is the test tube, the first layer will be your HDL, the second will be your LDL, and third you have your VLDL. Okay, no chylomicrons because chylomicrons is absent in fasting specimen. For your electrophoresis, so if this is your electrophoresis, so this is the point of origin or application of specimen. So the first migration band or migratory band, you have LDL. So this is LDL. This one is VLDL. And the last one, you have your HDL. So this one is your beta region. This one is your pre-beta region. And the last one, you have your alpha region. Okay. So for lipoprotein A, it has a density like like LDL, but the migration is like the or it's in the pre-beta region. So if the usual or the normal setup, if the density of a lipoprotein is like LDL, so the normal unta is the migration of that lipoprotein is here in the beta region. But in this case, the migration of lipoprotein A, it's in the pre-beta region. So same characteristic with VLDL in terms of migration, but the density and composition is same. It's the same with LDL. So this one is known as the sinking pre-beta lipoprotein. Why? It's because the migration is like pre-beta, okay, or same with VLDL. And remember, VLDL in ultracentrifugation, that's floating. It's because it's located in the top portion. But for this one, it's a sinking pre-beta lipoprotein because it's a VLDL, okay? In terms of migration, it's VLDL, but the ultracentrifugation result is like LDL. So LDL is located in the middle portion, meaning it's sinking. That's why it's a sinking pre-beta lipoprotein. Okay? And it's isolated in the LDL-HDL density range by ultracentrifugation. And if there's increased concentration of lipoprotein A, it's associated with premature coronary heart disease and stroke. And the major apolipoprotein, it's ApoB100 and ApoA. Okay, so ApoB100, if there's ApoB100, usually it is associated with atherosclerosis. Okay. Okay, so next you have abnormal lipoprotein. So for abnormal lipoproteins, example, you have lipoprotein X. It's usually found in obstructive jaundice and LCAT deficiency. And it's a sensitive indicator of cholestasis. Okay, so for cholestasis, meaning there is a decrease in the bile flow. Okay, maybe if there's an obstruction, basta the meaning of cholestasis, you have decreased bile flow. Okay, so for lipoprotein X, the lipid content is mostly phospholipid and free cholesterol. So these are the abundant main composition of lipoprotein X, and it contains ApoC and albumin. So albumin is not usually a component of lipoprotein, but for this one, albumin is uh, present in lipoprotein X. So that's why it's an abnormal lipoprotein. Okay, and regarding migration of lipoprotein X, it usually stays in the cathode. Okay, it does not migrate. Okay, no, it migrates, but it goes to the cathode instead of going to the anode. Okay, anode, that is the positively charged, and cathode is negatively charged. So lipoprotein X tend to migrate to the cathode, or the positively, oh no, negatively charged end of your electrophoresis. Okay. The next abnormal lipoprotein, you have your beta VLDL. So beta VLDL, this is your floating beta lipoprotein. Why floating beta lipoprotein? Okay. Floating beta lipoprotein because the um, migration of beta VLDL, it's in the beta region. Okay. So if the migration, it's in beta region, usually the ultracentrifugation result is in the middle. Okay, so ultracentrifugation, you have your VLDL, then LDL, then HDL. For electrophoresis, you have beta, pre-beta, and alpha. So in this type of lipoprotein, the migration is beta. So if beta, the migration rate is beta, usually the ultracentrifugation result, it's present in the second layer or the middle. Okay, but in this case, in this lipoprotein, the density is like VLDL. Okay, so it's a beta lipoprotein that floats. Okay, that's why it's a floating beta lipoprotein. Okay, and characteristic of beta VLDL, it's a VLDL rich in cholesterol, and it's usually found in type 3 hyperlipoproteinemia and this beta lipoproteinemia. So later we'll discuss the different types of lipoprotein abnormalities. So example, hyperlipoproteinemia, this beta lipoproteinemia. So for beta VLDL, it is usually formed if there's an abnormal IDL catabolism or conversion of IDL to LDL. Or if there's increased concentration of IDL, that's the cause of beta VLDL formation. Okay? So if there's a problem with the conversion of IDL to LDL. Okay? Okay, so next is you have your lipoprotein methodology. So generally, total chole, triglyceride, HDL can be satisfactorily analyzed in frozen samples. And LDL concentration can be estimated with the Friedwald equation. Okay, so for total chole, you can measure total chole using enzymatic method. Same with triglyceride. And for HDL, you can perform chemical precipitation and afterwards you perform enzymatic method. For LDL, it's usually estimated. It's a result of estimation lang. Whether you perform the Fried or you'll use the Friedwald formula or the beta quantification. So for beta quantification, it also involves ultracentrifugation, but in the end, we're going to compute for the concentration of LDL, or you're going to have an estimation lang of LDL concentration for beta quantification. Now, regarding lipemic samples, it's usually collected from a patient with hyperlipidemia and also patients with total parenteral nutrition therapy, or you're introducing nutrients or food via IV. Okay, and also for non-fasting specimen. Non-fasting specimen has high level of chylomicrons. That's why it's usually lipemic. But for triglyceride measurement, the patient should fast for at least 12 to 14 hours. Okay, so that's for one way of eliminating lipemia from the specimen. Okay, so lipemic samples, usually it's pre-treated by ultracentrifugation to remove lipids like your chylomicrons. Okay, you can remove uh, some of the lipids using ultracentrifugation because chylomicrons is the least dense, so it floats. Okay, then for another, if you want to measure non-HDL concentration, the formula is you have your total chole minus HDL cholesterol, and that's your non-HDL cholesterol or other major lipoproteins like LDL, VLDL, and chylomicrons. But usually chylomicrons is absent in a fasting specimen. Okay. Then next, the specimen requirements or sample requirements for for lipids and lipoproteins. So using serum separator tubes is the preferred specimen or sample. Okay. Uh, for this one, it means nga you can use serum for the measurement of lipoproteins. Okay. So that's for example, if you want to measure HDL concentration, you're allowed to use serum as your specimen. So acceptable, it's either plasma or serum. But if you're going to use plasma, then use EDTA as the anticoagulant. Okay. Do not use heparin because heparin can affect electrophoretic mobility. So especially if you're going to separate proteins or no, separate lipoproteins using electrophoresis, it's not good to use heparin because it affects the electrophoretic mobility of lipoprotein. So the preferred is to use EDTA if you're going to perform ultracentrifugation or electrophoretic methods or electrophoresis. Okay. The next, patient preparation. So the patient should fast for at least 12 to 14 hours. Fasting is required when triglyceride and LDL concentration will be measured. Okay. But if the request is to measure um, cholesterol and HDL, fasting is not a requirement na. Okay. So fasting state, tag is present in VLDL. So if the sample is a fasting specimen, the triglyceride concentration or triglyceride is usually present in VLDL because VLDL is the transport protein of endogenous triglyceride. For fasting specimen, chylomicrons is absent. Okay, so non-fasting state, tag is present in chylomicrons primarily. Okay, because chylomicrons transport exogenous triglyceride. Okay, and non-fasting sample, usually you can use non-fasting sample for total chole and HDL because fasting does not affect, or the recent meal does not affect total cholesterol and HDL concentration. Okay, so for fasting, uh, no, triglyceride and LDL requires fasting specimen. Okay, no, no, triglyceride and LDL require, okay, fasting specimen. Okay, because if the patient did not fast, the triglyceride concentration will be falsely increased. Same with LDL, because LDL is just an estimation, and for LDL estimation, you need VLDL concentration. Okay, so for VLDL, you're going to use the triglyceride concentration divided by 5 or divided by 2.175. So the patient should fast for TAG and LDL, but for total chole and HDL, no need to fast. Okay. So for posture, standing patient reclines, extravascular fluid transferred to the vascular system. So this one can cause dilution. So the patient should be seated for at least 15 minutes. So this is 15 to avoid hemodilution, okay, and also hemoconcentration, okay. Then recommendation, initial screening for atherosclerosis, or to check the risk for atherosclerosis, 20 years old. So testing should be repeated at least once every 5 years. So if your age is 20 na, then you can start checking your cholesterol level and other markers for atherosclerosis, okay, to prevent or to avoid cardiovascular diseases. Okay, so test your lipid panel every 5 years, okay, to prevent or to detect early uh, risk, okay, or increased risk for atherosclerosis. Okay, now regarding lipoproteins, you can measure or separate lipoproteins based on its density. And if we based on its density, we can use ultracentrifugation. Then next, you have charge and size. Okay, so for charge and size, you have electrophoresis. Then for apolipoprotein content, for example, ApoB100, you have your immunochemical methods. Okay, so those are the three properties that you can capitalize in order to measure the different lipoproteins. Okay. So regarding ultracentrifugation, it's common in research laboratory, but it's usually uncommon in clinical laboratories. And ultracentrifugation is the reference method for lipoprotein quantitation, specifically for HDL. So HDL, the reference method is ultracentrifugation, and it is based on protein and tag content of lipoprotein, or the density. So the higher the protein concentration, the density is also increased. Okay, so it's directly proportional, the density and protein composition. So frozen samples are not appropriate for ultracentrifugal analysis because the tag-rich LPP, or lipoprotein, do not withstand freezing. Example of tag-rich lipoprotein, you have your VLDL. Okay, so it's better to use fresh specimen for ultracentrifugation or ultracentrifugal analysis. So next is electrophoresis. So for visual display, it's visual display uh, is useful in detecting unusual or variant pattern, okay, or pattern of lipoproteins. So for this one, you need agarose gel. So agarose gel is the medium that is usually used to separate lipoproteins. So for the purpose of electrophoresis is to separate lipoprotein based on its size and charge. Okay. And the purpose of electrophoresis is to give you a visual display, okay, or to give you patterns of lipoproteins. Okay, so after separation, you can use oil red O, fat red B, or Sudan black as dye. And for the electrophoresis, um, chylomicrons remain at the origin, but usually chylomicrons is absent in fasting specimen, and we usually use fasting specimen for electrophoresis. So that's why chylomicrons is usually absent. But if there is presence of chylomicrons will remain at the origin or the site of application of the specimen. So for electrophoresis, it's more of qualitative, okay, because it gives you pattern, and it's less desirable for lipoprotein quantitation because of poor precision. Okay. Next, chemical precipitation. So for chemical precipitation, this is uh, usually used to um, separate um, separate HDL, okay, or to measure HDL. So you're going to use polyanions like heparin in order to cause precipitation, okay, with other lipoproteins, and the lipoprotein that will remain in your sample, it's your HDL, okay. So later we'll discuss the principle of chemical precipitation, okay. So in electrophoresis, you have three main migratory bonds or migration bonds. You have LDL, VLDL, and HDL. So this one is alpha, pre-beta, and beta. So chylomicrons stays at the point of application or origin, but usually chylomicrons is absent in a fasting specimen, or it's not usually lang, it's absent in fasting specimen. So chylomicrons is not part of electrophoresis. But if you're going to use non-fasting specimen for electrophoresis, then you can uh, separate chylomicrons because it stays at the origin. Okay. Next, electrophoresis of lipoproteins in hyperlipidemia. So these are examples of electrophoretic pattern of lipoprotein. So the normal pattern is like this one. Okay, so this is your LDL, VLDL, and HDL. Okay, so LDL has higher peak because LDL is the most abundant lipoprotein, followed by VLDL, and last you have your HDL. So for type 2 hyperlipidemia, you have increase, okay, of this one because of increase in IDL, because IDL migrates between beta and pre-beta. So this one is beta, this is for LDL, and pre-beta, your VLDL. So in type 3 hyperlipidemia, there is increased IDL. That's why there is a peak here, right here. Okay. And for type 4, you have increased this one in this area, pre-beta. So for type 4, you have increased VLDL. That's why the peak is right here. Okay, it's increased. And for type 5, you have a peak right here because of chylomicrons. Okay. Uh, Chylomicrons, di ba, I stated earlier that chylomicrons is absent in fasting specimen. But there is a type of lipoprotein or lipid disorder that there is increase in chylomicrons even in fasting serum. So correct ra gyapon itong usually, okay? Chylomicrons is usually absent in fasting specimen. But there are cases like hyperchylomicronemia. In hyperchylomicronemia, there is excessive or abnormal increase in chylomicrons even in fasting specimen because it's a condition. So there's a peak right here because this is the site of origin. So increase chylomicrons, and there's also increase in the pre-beta region or increase in um, very low density lipoprotein or VLDL. So these are the examples of patterns, electrophoretic patterns of lipoprotein. So regarding electrophoresis, it's usually qualitative, so you can view the patterns, but you cannot point out the exact concentration. Okay. So if you want to measure the exact concentration, then it's better to use ultracentrifugation. So remember regarding chylomicrons, it's usually or it's absent in fasting specimen. But if the patient has hyperchylomicronemia, which is a condition or lipid disorder, chylomicrons is still present or is present even in fasting specimen. Okay? Because there's a problem with the concentration of chylomicrons. Okay? So in a healthy individual, chylomicrons is absent in fasting specimen. But in cases of or in patients with hyperchylomicronemia, or example of lipid disorder, so chylomicrons is increased even in fasting specimen. Okay? Next is you have immunochemical methods. So it has the potential for both research and routine use. And for immunochemical, we're going to use antibodies that is specific for certain lipoproteins. So it's an immunoturbidimetric assay, and it's usually used to measurement of lipoprotein A. Okay, so we will employ or use turbidimetry for this method. So the principle, for example, your ApoB, I don't know, for your LDL. So LDL contains ApoB100. This is the predominant apolipoprotein in LDL. So in order to measure LDL, we're going to add anti-ApoB100. Okay. So this antibody will react with ApoB100 to form an antigen-antibody complex or apolipoprotein antibody complex. So instead of antigen, the antibody will react with the apolipoprotein. And since there's apolipoprotein antibody complex, you can use turbidimetry to measure the concentration. Okay, so that is for immunochemical method. And regarding antibody, it's usually specific. Okay, so this method has a potential to be used in both research and routine analysis. Okay. Next, you have HDL measurement. So for HDL measurement of HDL cholesterol has assumed greater importance in the latest NCEP treatment guidelines or National Cholesterol Education Program. That's in NCEP. So you need it to include HDL cholesterol measurement with total cholesterol in the first medical workup. So for example, if you're a doctor and you have your patient, so if you are going to request for total cholesterol, might as well include HDL in the measurement or testing in order to correlate the total chole with HDL concentration. And for the routine test for HDL, it's your chemical precipitation. Okay, so for chemical precipitation, you can use heparin plus manganese as precipitant. But the problem with this precipitant, it can interfere with enzymatic assay. Now, for HDL, the first step is chemical precipitation and the second step is enzymatic. Okay, so heparin and manganese, it's not that good to be used for HDL precipitation. Another, you have sodium phosphotungstate plus magnesium as precipitant. But this one is sensitive to reaction conditions and greater variability. So it's prone to variation of the results because these precipitants, if you're going to use this one, they're sensitive to reaction conditions. So for example, the pH, the temperature, okay? So the most common precipitant used for chemical precipitation for HDL, you have dextran sulfate plus magnesium, okay? So the principle, so first you have your serum specimen, and your serum specimen contains the major lipoproteins, except for chylomicrons in fasting specimen. Okay, but as I've said earlier, if the patient has a condition like hyperchylomicronemia, then chylomicrons is still present in fasting specimen if the patient has hyperchylomicronemia. Okay. So next is um, you have your specimen that contains lipoproteins, including HDL. Now we want to measure HDL. So this serum specimen must be mixed with the precipitant. Okay. So after that one, next is you centrifuge. Okay, the solution. So after centrifugation, you have two layers. So the precipitant or the precipitate and the supernate or supernate and the infranate. Okay. Now this supernate contains your HDL because the function of precipitant is to cause precipitation to other lipoproteins. So this one, the precipitate contains the non-HDL lipoproteins or non-HDL cholesterol. Okay? So your supernate contains your HDL. And HDL contains cholesterol, diba? So that's why it's HDLC or HDL cholesterol. So the next step is to add cholesterol reagent in order to measure the cholesterol concentration of the supernatant or the supernate. And that concentration of cholesterol, that's the concentration of your HDL. Okay? So remember, HDL carries cholesterol. So we can use cholesterol reagent to react with HDL, and that reaction or that first is, 'di ba, for the procedure, serum plus the precipitant. The purpose of adding precipitant is to precipitate the non-HDL cholesterol. Okay? So after centrifugation, you have two layers, the supernatant or supernate and the precipitate. That precipitate at the bottom contains the non-HDL cholesterol. So the supernatant contains the HDL chole. Since HDL carries cholesterol, we can use cholesterol reagent to measure HDL because that cholesterol reagent will react with the cholesterol component of HDL. So after that reaction, you have your absorbance, then compute for the concentration. That concentration of cholesterol signifies, or that's also the concentration of HDL. Okay? So that's how we measure HDL using chemical precipitation and enzymatic method. So the first step is chemical precipitation. Second, you have enzymatic using cholesterol reagent. Okay. Next, the reference method for HDL measurement. So the reference method is by using ultracentrifugation, and it involves three steps. So first is ultracentrifugation, the next is the addition of heparin manganese, and to use Abel-Kendall assay. Abel-Kendall assay is the method for cholesterol measurement. But for this one, instead of directly use precipitant, we're going to use ultracentrifuge. So first, you have your ultracentrifuge, and the purpose of this one is to separate the lipoproteins. So after ultracentrifugation, you have two layers, the infranate and the supernate. The supernate, the upper layer, contains the VLDL. Okay? And the infranate contains LDL and HDL. Okay? So infranate, this one, contains HDL and LDL. So for the next step, we're going to use the infranate. So we'll discard the supernate and use infranate. So for this method, we're going to use infranate. For chemical precipitation, we're going to use the supernate. So after that one, we use the infranate and add heparin manganese to the infranate. The purpose of adding the heparin manganese, okay, to the infranate is to cause precipitation to LDL chole. Okay, so after that one, next is to measure HDL chole or the cholesterol component of your HDL using Abel-Kendall assay. Okay, so for chemical precipitation, it's a two-step process. for the CDC reference method for HDL, it is composed of, you have 3 steps. The first step is ultracentrifugation. The next is the addition of the precipitant. Then after that is to measure the cholesterol concentration. Okay, so the purpose of adding the heparin manganese is to cause precipitation to LDL concentration because we want to measure HDL. Okay, so that is for the reference method for HDL. The next is LDL measurement. So for LDL measurement, it's proven to be atherogenic, to be an atherogenic lipoprotein, and it's the primary basis for treatment decision. And it is the most important value in assessing cardiac risk and redirecting therapy or lowering cholesterol lowering therapy. And it is the reference method. No, the reference method for LDL measurement. It's beta quantification. So how to perform beta quantification? Okay, so for beta quantification of VLDL, no, LDL, you need serum specimen. And for the serum specimen, first is you need to measure the total cholesterol concentration using enzymatic method. And after, measure the HDL concentration using chemical precipitation. And after chemical precipitation, you'll use cholesterol reagent to measure the cholesterol concentration of HDL or to have the HDL concentration. Then after that one, use this specimen or place this one in an ultracentrifuge. And after ultracentrifugation, you have 2 layers. So first is the infranate, and second you have the supernate. So this one is the supernate. At the bottom you have the infranate. So the supernate contains your VLDL, and the infranate contains LDL and HDL. Okay. So next is to remove the supernate and use the infranate for the next procedure or the next step. So the next step is to add cholesterol reagent. Okay. So infranate plus cholesterol reagent, then you have cholesterol concentration of the infranate. Okay. So this cholesterol concentration of the infranate signifies the concentration of both LDL and HDL. So it's not specific. So for us to get the value of LDL, we'll use the formula LDL is equal to the cholesterol concentration of the infranate minus the HDL concentration before ultracentrifugation. So you need this one, the cholesterol concentration of the infranate minus the HDL concentration prior to ultracentrifugation. And that is your LDL concentration. Okay, so that's for beta quantification. So next is the Fredwold formula. So this is the routine method, okay, for LDL estimation. So we'll use Fredwold formula to get an estimate of LDL concentration. So it's common to both research and clinical laboratory. And for Fredwold formula, it's invalid once the triglyceride concentration of the patient exceeds 4.5 millimole per liter or greater than 400 milligrams per DL. Okay, and it's not suitable for non-fasting sample because the kilomicrons in non-fasting sample can cause overestimation of the VLDL concentration and so the LDL concentration. So for VLDL, you need to no, for LDL to estimate or to compute for LDL, the formula is LDL is equal to total chole minus HDL minus VLDL. So for this one, it's determined using enzymatic method. And for HDL, it is determined via chemical precipitation. And after chemical precipitation, you have your enzymatic method. For VLDL, uh, it's usually estimated from your triglyceride concentration. So if the unit of your triglyceride concentration is in millimole per liter, then plasma tag divided by 2.175, that is the formula. If the unit is mg per dl, then tag concentration divided by 5, and that is your VLDL concentration. So both VLDL and LDL are estimates lang, estimation, okay? So we can measure total chole and HDL, but for LDL and VLDL, it's estimation. Okay, it is an estimate. Okay. Okay, so next is we'll discuss lipid disorders. And first example of lipid disorders, you have Tanger's disease. So for Tanger's disease, this is also known as your hypoalpha lipoproteinemia. So meaning the concentration of HDL is decreased. So HDL concentration is low due to mutation in ABCA1 gene. Okay. So this mutation in ABCA1 gene is the cause of decrease in HDL. Okay, so in Tanger's disease, the usual concentration of HDL is less than 24, okay, mg per dl. The uh, the minimum, okay, concentration of HDL is 35. If it is less than 35, then you'll have high risk for atherosclerosis. But for Tanger's disease, it's less than 24. Okay, so decrease in HDL concentration due to the mutation of ABCA1 gene, because ABCA1 gene on chromosome number 9, that is responsible for HDL production. Okay, so there is high density lipoprotein deficiency, and it is an inherited disorder. Okay, so if there is decrease in HDL concentration, cholesterol tend to accumulate within the cells, diba? The function of HDL is to remove the excess chole from cells. Okay, so from the cells, that's the function of HDL, to remove extra or excess cholesterol. Now the problem with Tanger's disease, the HDL concentration is low, so the cholesterol molecule, okay, the cholesterol will tend to accumulate inside the cell because there is no HDL that can remove the excess chole. Okay, so in Tanger's disease, the cholesterol level is increased, the LDL concentration is normal, but the HDL concentration is low. Okay, cholesterol level is increased, so patients with Tanger's disease are prone to atherosclerosis or prone to cardiovascular diseases, but the LDL concentration is normal and HDL concentration is low. So that is for Tanger's disease. Okay. Next is Tay-Sachs disease. So for Tay-Sachs disease, there's a deficiency in the enzyme hexosaminidase A, and that enzyme is important in the breakdown of sphingolipids. So in Tay-Sachs disease, there is accumulation of sphingolipids in the brain, and sphingolipids is toxic to the brain and spinal cord. So it can cause nerve damage, and if there's nerve damage, the effect, you have weak muscle or paralysis. Okay, so you'll have problems with your nerves, and if the nerves are affected, usually it has a lot of problems. Okay, so children with Tay-Sachs disease have very short lifespan. Okay, it's because of the problem with the nerves, and once there's a problem with nerves, usually all of your functions will be affected. Okay. Okay, so next is you have a beta lipoproteinemia. So for a beta lipoproteinemia, there is a mutation in MTTP gene. Okay, so for Tanger's, you have ABCA1 gene mutation. For a beta lipoproteinemia, you have MTTP gene mutation. So MTTP is microsomal triglyceride transfer protein gene. Okay, so if there's a mutation in MTTP gene, then this one will lead to decreased production of ApoB. Okay, ApoB synthesis, or decreased production of ApoB. Okay, or decreased synthesis or decreased production of ApoB. And for ApoB, uh, lipoproteins that contain ApoB, you have LDL, VLDL, and chylomicrons. Okay, so LDL, this is ApoB 100. Same with VLDL, and for Kylo you have ApoB48. So if there is MTTP1 gene mutation, then ApoB synthesis is decreased. So the LDL concentration is decreased, same with VLDL and chylomicrons. Okay, so there is undetectable LDL concentration. So LDL is absent, not just deficient. So for ApoB lipoprotein, there is failure to synthesize ApoB. So that's why there's decrease in LDL, VLDL, and chylomicrons. Okay. So for definitive diagnosis, you perform immunochemical demonstration of the absence of LDL ApoB in the plasma. Okay. Now for ApoBeta lipoproteinemia, so you have decreased LDL, VLDL, and chylo, meaning you have decreased cholesterol and decreased triglyceride. Okay, because you have decrease in LDL, VLDL, and chylomicrons. Now, since there is decrease in chylomicrons, so the absorption, okay, absorption of fats, absorption of lipids, uh, uh, the patient will have problems with the absorption of fats. Okay, so the patient will have or will experience steatorrhea or oily stool. Okay, it's because of fat malabsorption. There is fat malabsorption because of chylomicron deficiency. Okay, because chylomicrons is important in the absorption uh, of uh, of lipids. Okay, chylomicrons. Okay, now regarding vitamin A, D, E, and K, vitamin A, D, E, and K, vitamin D is not affected in a beta lipoproteinemia because vitamin D is absorbed without the aid of chylomicrons. But vitamin A, E, and K are affected. Why? It's because A, E, and K, the absorption of A, E, and K they need chylomicron for the we need chylomicron in the absorption of A, E, and K. Now, between these three vitamins, the vitamin that is highly affected with this beta lipoproteinemia, it's vitamin E. Because vitamin E needs chylomicrons in the absorption, and also vitamin E needs LDL and VLDL in the transportation. Okay, so the highly affected vitamin, it's vitamin E. Okay, now since these vitamins are affected, A and E, vitamin A and E, are important uh, ano yan are important in the maintenance of the health of our nerves. Okay, so nerve health, you need A and E. Now the problem with a beta lipoproteinemia, you have decreased vitamin A and E, especially E. Now these vitamins are important in nerve health. So if there's a problem with vitamin A and E, the patient will experience cerebral ataxia. Okay, cerebral ataxia. Okay, meaning of ataxia, you have poor muscle coordination. Why there's poor muscle coordination? Because the nerves are affected because of low, or there's a problem with the nerves because of low concentration of vitamin A and E. Okay. Then next, so you have oily stool. For a beta lipoproteinemia, there is oily stool because of fat malabsorption due to chylomicron deficiency. Then cerebral ataxia because of vitamin A and E deficiency. Okay, because A and E and K, they need chylomicron for absorption. Okay, and E needs lipoproteins for transportation. That's why there's cerebral ataxia because of decrease in these vitamins. Okay, another, this is also a diagnostic, okay, uh, result in a beta lipoproteinemia. It's the presence of acanthocytosis, okay, or acanthocytes. So for acanthocytosis, you have increase in the number of acanthocytes, and acanthocytes or your spur cells. Okay, so there's a presence of sperm cells, spur cells. It's because of spur cells. It's because or acanthocytes. It's because of the problems with the concentration of lipids. Now remember, lipids are important in maintaining, or for example, cholesterol, it's important in maintaining the fluidity of the cell membrane. So in a beta-lipoproteinemia, there's a problem with cholesterol concentration. Why? The LDL concentration is low. So the cholesterol concentration is also low. Okay? So there will be problems with the membrane of the red blood cells. And since there's a problem with the membrane of the red blood cells, it will present as the presence of acanthocytes or acanthocytosis. So you have spur cell formation because of decrease in cholesterol concentration, which is important in maintaining the health of or maintaining the integrity of the cell membrane. Okay? So let's go back. For a beta-lipoproteinemia, there is MTTP gene mutation. And since there's MTTP gene mutation, the effect, you have ApoB, decreased production of ApoB. Now for ApoB, that's the apolipoprotein in LDL, VLDL, and chylomicrons. So for LDL, you have ApoB 100, VLDL ApoB 100, and for chilo, it's ApoB 48. So meaning in beta lipoproteinemia, you have decreased LDL, decreased VLDL, and decreased chylomicrons. And since there is a decrease in LDL, the concentration of cholesterol is decreased. Okay? Since there's a decrease in cholesterol, the membrane of RBCs are affected because cholesterol is important in maintaining the integrity of the cell membrane. So the effect, you have the formation of acanthocytes or spur cells. So there is acanthocytosis. Okay. Then next, you have decreased VLDL and chylomicrons. So the effect, you have decrease in triglyceride concentration. Now, since there is a decrease in chylomicron level, then the next thing that will happen, the patient will have oily stool because chylomicron is important, or chylomicrons are important in the absorption of fats. So in a beta lipoproteinemia, there is fat malabsorption due to chylomicron deficiency. Okay, so oily. Now, since there is also chylomicron deficiency, we'll have problems with vitamin A, E, and K because A, E, and K are dependent on chylomicrons for absorption. Okay, so the patient will have vitamin A, E, and K deficiency. And remember, A and E are important in maintaining nerve health. So if there's a problem with vitamin A and E, so the nerves will have problems with uh, the patient will experience nerve problems, and it will manifest as cerebral ataxia. So for cerebral ataxia, there is poor muscle coordination due to nerve damage. Okay, so that's the flow for a beta lipoproteinemia. Okay, so next lipid disorder, you have hypo-beta lipoproteinemia. So hypo-beta lipoproteins, meaning decreased concentration in LDL. So since there's a decrease in the concentration of LDL, the concentration of cholesterol is also decreased because beta lipoprotein is the transport protein for cholesterol. Then next, lipid disorder, you have mixed hyperlipoproteinemia. So for this one, there's increase in VLDL and increased chylomicrons even in fasting specimen. Okay, so this one is usually a continuation of uh, hyperchylomicronemia. Okay, so same with hyperchylomicronemia, there is the problem with LPL. Okay, So there is LPL deficiency or problem with the lipoprotein lipase that is important in the breakdown or catabolism of chylomicrons and VLDL. So for mixed hyperlipoproteinemia, usually the concentration of triglyceride, it is greater than 1000 mg per dl. And the reason why this is increased, there is increase or very high triglyceride concentration. It's because of the increase in chylomicrons and VLDL. So this one is a common cause, or it can cause pancreatitis, because in hyperlipoproteinemia, mixed hyperlipoproteinemia, or uh, type 4, okay, of lipid disorder, according to Fredrickson classification, um, there is increase in triglyceride concentration. And if there's a continuous increase in triglyceride concentration, this can cause occlusion of the uh, pancreatic capillaries. And if there's occlusion of the pancreatic capillaries, it will lead to ischemia. And that ischemia can cause damage to the pancreatic cells. So that's how pancreatitis occur in mixed hyperlipoproteinemia. So it's usually common in adults, and the LDL and HDL concentration are normal for this type of disease. Then plasma is opaque, okay, and there's a floating creamy layer above the turbid plasma. So upon prolonged standing of plasma, you have a turbid plasma, okay, and a creamy layer above, or a creamy layer that is floating. So that creamy layer is consist of chylomicrons. And the reason why there's turbidity of the plasma, it's because of the VLDL. Okay, so this is the characteristic of specimen in patients with mixed hyperlipoproteinemia. So there's a creamy supernatant, this one, a creamy layer above the turbid plasma. So that is for mixed hyperlipoproteinemia, or type 4, okay, hyperlipidemia, okay? Oh, no, type 5 hyperlipidemia. Next is dis beta lipoproteinemia. So for dis beta lipoproteinemia, characteristic, there is increase in chole and triglyceride due to abnormal LDL. Okay, so there is a problem with VLDL catabolism. Okay, so there is increase in IDL. So abnormal LDL merges with pre-beta bond on electrophoresis to produce a broad beta bond. So for this one, there is the presence of floating beta lipoprotein. Okay, so floating beta lipoprotein for this beta lipoproteinemia. Okay, and in this lipid disorder, there's increase in TAG and chole, okay, due to increase in the floating beta lipoprotein, okay, and the VLDL concentration is also high, but the LDL and chylomicron concentration is normal. Okay, so for this beta, you have increase in TAG, increase in chole due to increase in VLDL, and the presence of floating beta lipoprotein, okay, or your beta VLDL. So that's for this beta lipoproteinemia. So this one appears because of abnormal VLDL catabolism, okay. So that is for this beta lipoproteinemia. So LDL concentration is normal, okay, but the VLDL concentration is high, and there's the presence of beta VLDL, okay. So for beta VLDL, it's a VLDL rich in cholesterol, okay. So your floating beta lipoprotein is rich in chole. That's why TAG and chole are high in this type of lipid disorder. Next, you have hyper pre-beta lipoproteinemia. So hyper pre-beta, meaning increased VLDL. Okay. So there is endogenous hyperlipemia. So in this disease, there's an increase in triglyceride due to increase in VLDL. Okay. So for this one, the LDL concentration is normal, but there is increase in VLDL due to increased carbohydrate intake. Okay, remember, if there is an excess in carbohydrates or increase in glucose, that excess glucose will be converted to fat. Okay, and the product have increase in VLDL or increase in endogenous triglyceride. Okay, so there is endogenous hyperlipemia. So for this one, you have increased intake of carbs, so meaning you have excess glucose. Okay, that excess glucose will be converted to fat. Okay, or increased formation of your VLDL that carries or transport endogenous triglyceride. Okay, so that is for hyper pre-beta lipoproteinemia. It's usually caused by lifestyle. Okay, so there's increase in VLDL, and since there's increase in VLDL, there's also increase in triglyceride. But in this situation, the specimen usually does not contain chylomicrons. The reason why it's lipemic is due to the VLDL, not chylomicrons. Okay, and for electrophoresis, there is a distinct pre-beta band, meaning increase concentration in the pre-beta region because of increase in VLDL. Okay, so that's for hyper pre-beta lipoproteinemia or type 4 lipidemia. Okay, so for this beta lipoproteinemia, that's type 3. This one is type 4. Okay, then next you have combined hyperlipoproteinemia. So for combined hyperlipoproteinemia, you have increase in chole and increase in triglycerides. So meaning there's increase in VLDL and also increase in LDL. Okay, so for this one, since you have increase in LDL, you have increased risk for coronary heart disease. Okay, so that's for combined hyperlipoproteinemia. Increased chole, increased TAG due to increase in VLDL and LDL. So this one is uh, combined is type 2B. Okay, hyperlipidemia. Okay, so next is hyperchylomicronemia. So for hyperchylomicronemia, it's not associated with coronary heart disease because in this particular disease or lipid disorder, the lipoprotein that is elevated is only chylomicrons, and chylomicrons is not atherogenic. That's why it's not associated with CHD, but it can cause pancreatitis. Okay, so for pancreatitis, uh, same with mixed hyperlipoproteinemia, you have continuous increase in TAG that can cause occlusion. Okay, occlusion of the um, pancreatic capillaries, and that occlusion in the pancreatic capillaries that can cause ischemia, and that ischemia can cause uh, damage to the pancreatic cells. Okay, so that's for pancreatitis. Then next, you have decreased lipoprotein lipase, so meaning no clearance or catabolism of chylomicrons. So chylomicrons will stay in your system for a long period, and that's the reason why the sample is turbid. Okay, so for this one, since there's increase in chylomicrons, the TAG concentration is also increased. And the cholesterol level, it's normal, LDL is normal, VLDL is normal, but the chylomicron concentration is increased, okay, due to LPL or lipoprotein lipase deficiency. Then features of this disease, low cardiac risk because the lipoprotein that is increased, it's only chylomicron. But you have eruptive xanthomas, so meaning of xanthomas, you have the buildup of fat under the surface of the skin. Okay, it's due to accumulation of fat. Okay, that's xanthoma. Okay, then next is the recurrence or recurrent pancreatitis due to increase in very high concentration of triglyceride, and there's a creamy layer over a clear plasma. So for this one, the plasma is clear, but the supernatant, uh, it has a creamy layer, and that creamy layer is due to the increase in chylomicrons. So the plasma is clear because of a normal VLDL concentration. Okay, so upon prolonged standing. Okay, and that's for hyperchylomicronemia. Okay, so next is hypercholesterolemia. So for hypercholesterolemia, this is a type of lipid disorder that is usually linked to heart disease. So for familial hypercholesterolemia, meaning because of genetics, so for example, both parents have hypercholesterolemia, so the product is a homozygote individual. So for homozygote individual, usually the concentration of cholesterol is from 800 to 1000 mg per dl, and the treatment for this one is through LDL pheresis or removal of excess LDL. And for heterozygote, expected concentration of cholesterol is from 300 to 600, and the medication is to use statin. Okay, now in hypercholesterolemia, the problem is the LDL receptor. Okay, the presence of defective or absence of LDL receptor. Okay, so since there is no LDL receptor, the LDL will tend to accumulate in the circulation. Okay, so and that can cause after that there is oxidation of LDL, and after the oxidation of LDL you have the engulfment of LDL by macrophages. Then after the engulfment, since macrophage cannot digest LDL, so that will become what do you call this, foam cell, and those foam cell will accumulate in the lumen of the artery, and that cause occlusion. Okay, so that is for hypercholesterolemia. So there's a problem with LDL receptor for familial hypercholesterolemia. So LDL is increased, so total cholesterol is also increased. So for homozygote, it's 800 to 1000. For heterozygote, it's 300 to 600. In terms of medication or management, for hypercholesterolemia, homozygote, it's LDL pheresis or the removal of LDL. For heterozygote, the use of statin medications. So this one is type 2A hyperlipidemia using the Fredrickson classification. Okay, so next you have the Fredrickson classification of hyperlipidemia. So first you have type 1, type 2, type 2B, type 3, type 4, and type 5. So for type 1 or hyperchylomicronemia, so in hyperchylomicronemia, the chylomicron concentration is high. Okay, so the triglyceride concentration is also high because chylomicron transport exogenous triglyceride. Okay, VLDL is normal, LDL is normal. That's why cholesterol concentration is normal. Then for type 2A familial hypercholesterolemia, you have increased LDL due to defect or problem with LDL receptor. So since LDL is high, the concentration of cholesterol is also high. Okay, the concentration of VLDL and chylomicron it's normal. That's why the tag concentration is also normal. Then next, type 2B, familial combined hyperlipidemia. So combined hyperlipidemia, so increase LDL and VLDL. So effect, you have increase in triglyceride due to increase in VLDL, then increase chole due to increase in LDL. Chylomicrons is normal. For type 3, familial dysbeta lipoproteinemia. So LDL is normal, but there is a presence of beta VLDL or VLDL rich in chole. And there's also presence of increased concentration of IDL. So the concentration of TAG is increased and also cholesterol. Then next, for familial hypertriglyceridemia, okay, so this one you have increased VLDL, okay, so that's why there's increase in triglyceride concentration. LDL is normal, so the concentration of cholesterol is also normal. So for mixed hyperlipoproteinemia, you have increased VLDL and chylomicrons. Okay, so effect, you have high levels of triglyceride and also high levels of cholesterol. Okay, so because the product of VLDL catabolism have no, for this one is Since VLDL will not be catabolized, there's a tendency to form um, uh, beta VLDL. That's why there's increase in cholesterol. Okay, so that's all regarding lipids.